So geriatric issues are an ever-increasing burden on the healthcare system. And ankle fractures are really not a big player in this mess of public health issues right now. But of course, ankle fractures do occur, and they do occur in the geriatric population. And what is the geriatric population? I don't know. Is it an age? Is it an age plus an X-ray appearance, bone density? But there's something called the Geriatric Society of America, which is a medical group of geriatricians. And they say if you have more than 2 chronic conditions and you're over 60 years of age, your problems and complications from surgery of any kind skyrocket. And if you have 3 or more, your chances of death go way up. So these patients differ from other younger adults. And the effort that we're all putting in to treat them in an optimum fashion is minimal. My research into this topic for this talk didn't come across very much evidentiary material. And as we all know from Medicare info, the last 6 months of a patient's life can consume up to 50% of the total cost for their lifetime care. So it's a biggie. Ankle fractures come in different flavors. They're open and closed. And I'll say this from the outset, I couldn't find anything on talar fractures in the geriatric age group, and that's an ankle fracture. But for the mortise, yes, there's some information, but not a lot of evidence. The most important thing is to know your patient. And of course, in the emergency room setting, not easy. But if you have someone who's geriatric in age and the number of medical conditions, my advice is to have medical backup. So the personality of the fracture will determine whether you're going to treat this non-operatively or operatively. Comminution of the plafond, for example, is of course an issue in treating all ankle fractures. But in someone who has pre-existing arthritis, not getting around too well to begin with, I wouldn't fuss over that too much. It's not going to make a big difference in their clinical outcome. Skin compromise and blistering, yeah, that's a big issue and it's tough. Vascular evaluation, I had any number of patients I've treated over the years who were pulseless when they came in for no damn good reason. They had pre-existing vasculopathy. That needs to be evaluated and treated either perioperatively or before you do surgery. And then the severity of ankle arthritis to begin with. Someone has a very severe ankle that was impairing their ability to get around. You may want to say, this is better with an ankle fusion or an ankle replacement when they get over the pain and swelling from the acute fracture. And there's no literature on that. That's just personal opinion. So the timing of surgery is usually not critical, and you want to optimize the condition of your patient. You want to, as with all ankle fractures, gain stability and have adequate alignment. Varus and plantar flexion contracture are to be avoided. Open fractures may require special wound management in the geriatric age group. Highly comminuted plafond fractures, consider a temporary X-fix and an early arthrodesis, or if you're really a gambler and want to try and hit a home run your first time at bat, come back and do an ankle replacement at some time early on. You have to, of course, be handling these tissues gently when you do operate. Time is of the essence. If you're putzing around for 2 or 3 hours in a geriatric patient with an ankle fracture, the number of complications go way up, and that's not just swelling and stiffness. That's pulmonary problems, stroke, and death. So this age group and the people with the comorbidities, something to really gain your attention. And then there are big challenges with postoperative care. You may ask them to be non-weight bearing, but that's not going to happen. they're going to walk on it. So you want to make a stable construct and protect them in a splint or a brace and make sure they can learn to walk with walking aids. But they're going to walk on it. They're going to put weight on it. And you have to consider putting these patients in a rehab facility early on where they can at least keep 2 or 4 sets of eyes on the patient and help with mobility. And you want to treat post-op edema early with anything from a pneumatic device to custom fitting stocking. So you want to gain ankle motion as always, but you can settle for a stiff ankle as long as it's plantar-grade. And patients oftentimes need to learn as a permanent part of their independence to use a walking aid and follow these patients forever, at least offer to follow them. Late problems maybe aren't so late. Equinus contracture, that's a big problem. Weak calf musculature and the whole limb being weak could be a big problem. Osteoporosis, that bone, osteoporotic bone heals. It doesn't heal very slowly, but it's not a guarantee that the bone's going to be stronger after a fracture or treatment than before. Ankle arthritis is part of the plan. As I said, you may start thinking of an arthrodesis or ankle replacement. And you also have to remember the ankle's pretty close to a set of joints that are pretty important, particularly the subtalar joint gets very stiff with ankle fracture treatment in the best of circumstances. And a geriatric group who may already have some arthritis and stiffness isn't going to get a lot better. So in summary, treat the patient. I think whoever put this symposium together, Ted, was good. They had an old surgeon talking about old patients. It's a good match. The fracture, you know, you're going to evaluate that and make a decision based upon the character of the fracture, but you have other things to be concerned about, including problems that you want to avoid, and follow the patients. You're going to be married to this patient because of your scar on their ankle. I learned that from Lenny Goldner a long time ago. But be ready for that and accept this as someone in your practice now. I do recommend you go to the Geriatric Society Health Services website. They have a curriculum for orthopedic residents, believe it or not. And it's mostly about arthritis and impairment due to weakness, but there is something about ankle fractures in there. You may learn something. Thanks for your attention. I hope you all had a great meeting.